I was asked to give you a talk on prostate cancer staging, which is exactly what this talk will be about. And it's a very important talk because when we think of prostate cancer, it's not just one thing. It's many different things, and you want to make sure you get treated for the thing you have, not for something that someone else has. So I think the first thing I want to do is read a letter from a girl that was away. I have a girl in college at USC, and she's studying. And so this is a letter that was written to her mom and dad. Dear Mom and Dad, I guess you've heard by now that the dorm burned. We were all in the basement smoking pot, and I guess somehow we set the dorm on fire. But no one was hurt, and we got most of our belongings out in time. Oh, and I'm getting married soon. You see, I have to because I'm going to have a baby. You'll meet Bob soon. He's got a really swell Harley. And so as a parent, we all are horrified by this sort of thing. And then, but the letter goes on. Actually, I'm not pregnant. And I don't even know anyone named Bob, and I'm not going to get married. There was no fire, and I wouldn't know what to do with pot, but I did flunk chemistry. And I just wanted you to be able to put that into perspective. And so this is a talk on perspective today. We want to put things into perspective, and I thought that would illustrate how things can change and priorities can change. When they thought that these parents were going to lose their daughter to either to Bob or to dope or to something, and that they got their daughter back, it really was a relief, even though this is not good news when you flunk chemistry, obviously. So, all right, so when you talk about prostate cancer, we're talking about something that generates, first and foremost, a lot of fear. And we're trying to keep our thinking straight as we go through the process of staging. I think I just hit my mark. Sorry about that. And so words have an incredible power. And when we're talking about staging, we talk about high-risk prostate cancer, advanced prostate cancer. These words are so scary, people stop thinking straight. And just to give you an example of that, the power of words, we think about, there's certain words we talk about them, we don't say them. They're so powerful. Four-letter words, although our culture is changing quickly now, and I'm hearing everyone use four-letter words, and I haven't been above that in my own time. But no, we still won't say the N-word, right? I mean, that's a really charged word. That we hear about these words like chemotherapy and radiation. Those are pretty heavy-duty words. I like this illustration here, the word Nazi. I have a new neighbor who's a Nazi. He's really a friendly Nazi. And he's really nice. And you guys probably think that just because he's a Nazi, he's a bad guy. But he's next door. He's a friendly guy. Now, I've just lost all credibility with you guys, right? Dr. Scholz, we thought he was a logical guy. He's an idiot. He thinks there's a such thing as a friendly Nazi out there, right? So these words, like prostate cancer, have a certain assumption attached to them we all think we already know. And so we have to be careful. And what we've done to try and defuse some of this prostate cancer fear is to rename some of these categories. So here's the categories. When we talk about staging prostate cancer, we talk about staging it into 5 separate categories. Low risk, intermediate risk, high risk, PSA relapse, and advanced. High risk, that sounds pretty scary right there. So what we decided to do is change it into shades of blue for each of these. And there's several reasons we've done that. One is it turns out that there are actually stages within the stages. So you can have a low risk, high risk. Or you can have a high risk, intermediate risk. Well, that sounds pretty cumbersome, as you can imagine. So what we did is that we assigned a shade of blue for each of these different categories, the 5 different categories, which we're going to go through individually and talk about what those categories are. This is what staging is about. Each of these things, stages, or different shades of blue as we call them, are quite distinct from the other. So if someone has this type of prostate cancer and hears about someone like this getting chemotherapy, obviously they get confused when really they have 2 very separate things. So we hope to reduce some confusion by this. We hope to get people aimed at the right type of treatment for what they have. And we hope to also diffuse some of the fears with this shades of blue methodology for staging. So what is the shades of blue rooted in? And you're not going to be asked how to memorize this. And I understand this is being videotaped as well. So you'll be able to go back over this more slowly in the future if you need to. But the components of the different stages of prostate cancer are based primarily on these 6 things. So we had 5 different shades, and the 5 shades are based on 6 different things. And we'll go through a little bit of how you determine that. We're not going to try and make it perfect because you can work that out in your own time. But it has to do with what previous treatment you've had. So you have the newly diagnosed or the people that have never had surgery or radiation, and then you have people that have relapsed or have advanced disease. So did they have previous treatment? The grading, everyone in here must know what a Gleason grade is by now. 6, by the way, there isn't less than a 6, for those of you who didn't know. It starts at 6, that's low. 7 is intermediate, 8 to 10 is high. The PSA, under 10, between 10 and 20, over 20. If they can feel a bump on the prostate or not. If they put 12 cores into the prostate, what percentage of them have cancer? And then, of course, imaging. And I imagine Dr. Almeida gave you a good introduction to imaging today. So this is, again, you're not going to be asked any questions on this, but you can see here the 5 shades of blue, and then the 6 different categories can help figure out which shade you belong into. And in fact, if you go to the nonprofit site, pcri.org, there's actually a computer algorithm. You can just put your Gleason score in, your digital rectal, your PSA, and it'll tell you what shade you are, if you need help on that. So I'm not going to go into that in any more detail. And I'm just going to jump into now, and we're going to talk about each of these 5 different shades. I can't resist a little bit to talk about the treatment of each shade, because really, what is the point of knowing your stage or your shade if you don't look at what type of treatment that's going to aim you at? That's really the goal, is to get the best treatment for what you as an individual have, not some generic treatment that might be good for the supposed generic prostate cancer patient. So if these are the components that make what we call the sky shade of blue, otherwise known as low risk in the standard medical jargon. And that means that there's no previous surgery or radiation. If the doctor does a finger exam, there's either a tiny nodule or no nodule. Gleason 6 and no higher, PSA less than 10. And if there's any scans done, like MRIs or ultrasounds, it doesn't show any cancer spreading outside the gland. This is what we call the sky shade of blue. And probably the backbone of this whole idea of good, worse and somewhat worse cancer is based in the grade of the cancer, the genetic makeup of the cells. And the genetic makeup of the cells really drives a different future for different people, depending on whether they're low grade, intermediate, or high grade. You can actually, the untrained eye can see the difference between the way these look on the microscope. And now studies are being done with genetics, and they're actually figuring out which genes make this different from this and this from this. But one of the sad things that has, happy and sad things, has been discovered is that this one here, which constitutes of the 250,000 men diagnosed every year, probably about 100,000 men, probably shouldn't have been called a cancer because it never spreads. And believe me, that has created some confusion. There's been discussion in official circles about changing it to naming it something besides a cancer because it doesn't spread. So monitoring is the primary treatment. Active surveillance. Is there anyone in the world, anyone in the room that hasn't heard of active surveillance in here? I'm sure it's already been covered somehow. And so if it's so harmless and it never spreads, why do we even need to watch it? Why not just send people home? Why make them nervous by getting their PSA tested all the time? The answer is that there's always a possibility of some higher grade disease, 7, 8, 9, or 10, that was missed on the biopsy. That's one possibility that needs to be watched for. And the other is that you still have a prostate in place. So if the prostate's still there, as a man ages, he can catch a new high-grade cancer. So they still need to be watched. But this doesn't spread. And I'm just going to show you a couple of studies. One study published in 2012 14,000 consecutive men that had radical surgery for grade 6 prostate cancer. And they know it's grade 6 in those people because they took their prostates out. Not one single case of metastatic disease to the lymph node. 14,000 consecutive cases. That's pretty impressive. What about mortality rates in men with proven grade 6? 1.2% at 20 years. That was all comers. And if at the time of surgery they found that the cancer was at least contained within the gland, the 20-year mortality rate from grade 6 prostate cancer right there. What is that, 3 in 1,000 or something? Or 3 in 10,000? I'm not good on math. Anyway, very few. So we need to be thinking of the sky type of prostate cancer a little differently, especially since the most popular treatment, surgery, has this sort of risk. And this is a good quality American hospital. This is not going to Thailand or something for surgery. This is like what happens here in the United States. So people that go through radical prostatectomy, 1 out of 250 dies within 30 days of the surgery. 1 in 25 has a major complication. 1 in 2, more than 1 in 2, develops erectile dysfunction. 1 in 5 ejaculate urine routinely. 1 in 6 have long-term urinary leakage. That's pretty sad treatment for someone who has a harmless condition. So this is why the people that have the sky type of prostate cancer need to be thinking of their situation a lot differently than the people that have the other types of prostate cancer. So that's where we're going to talk about sky. Now we're going to talk about Teal, otherwise known as intermediate risk. These are people also newly diagnosed or no previous local therapy. However, they have either grade 7, a PSA of 10 to 20, or a nodule. If you divided the prostate into 4 quadrants, the nodule would be felt in 2 of them, usually on one side. And then also without any scans showing extracapsular extension. EC means extracapsular extension. So right away, we start delving into a little more complexity because these people are generally thought to require some form of treatment. This is a prostate cancer that can spread over a period of many years, and over a period of many years, a very small minority of men can die of this. Maybe 5 to 10% of men could die of it. So we break it down into 2 categories, low risk and high risk Teal. So remember the old medical terminology, this is intermediate risk prostate cancer. And you can see why we like to give a color to this category of Teal rather than calling this low risk intermediate risk and high risk intermediate risk. I mean, this gets a little ridiculous, doesn't it? So low risk Teal means that the Gleason score is preceded with a 3 and follows with a 4. High risk means it starts with a 4 and ends with a 3. It means to be in this category, you have to have all of these. Less than half of the core biopsies are positive. So if there are 12 cores, that means 5 at the most. And there can't be multiple factors, like having grade 7, having a PSA of 10 to 20, and feeling a big bump, which is another thing. You can only have one of those. Then you're low risk. High risk, over half the cores, 2 or 3 factors positive, Gleason 4 plus 3. And just as a reminder, since this is a staging talk, people that get into the Teal and higher should have a bone scan and a body scan to make sure there's no lymph node spread, although the chances of finding spots with these scans is extremely low, probably at 5% or less. But for that 1 out of 20 patients, we do, we do scans in everybody. So just briefly, some thoughts. We're not going to go into a treatment talk today, but it gives a little context, gives a little perspective in terms of what these different categories mean. The types of things that you would talk about with the patient, which vary with the patient's age and sexual activity and other factors, could be even active surveillance. There are some patients with low risk Teal that could consider just watching it, or perhaps just a seed implant, or one of these standard radiation treatments. Focal therapies are a new thing where they're just freezing or lasering a spot inside the prostate. I'll even allow surgery to get on the list. I'm not much of a fan of surgery, but for this category, maybe. And hormone therapies, which is also unorthodox, but can suppress the disease for many years, but with a number of side effects. So what about treatment for high-risk Teal? Well, that gets a little bit more standardized. There have been a lot of studies done on this, and it appears that the optimal treatment is radiation beam, IMRT, intensity modulated radiation, seed implants, and about 4 months of hormone treatment. As an alternative, it's looking like high dose rate temporary seeds might be a substitute for this, that the cure rates with this may be as good as with this. I'm, again, less of a fan of surgery in this situation because there's a higher incidence of what we call positive margins after surgery. That means that because they can't cut in broad margin around the prostate, they leave a little cancer behind. And when a little cancer is left behind, then the doctor gives you the bad news that we're going to have to do radiation right after the surgery. And you're thinking, wow, maybe I should have just done radiation and skipped the surgery step. And that's the way I'm thinking. Let's just skip the surgery step and not end up in this situation. The situations where you might want to consider surgery, some men have very, very large prostates, and radiating a really big prostate can cause more side effects. And also, one of the most common side effects of radiation is irritative urinary symptoms, and radiation also tends to do that. So some men have, they're already getting up 3 or 4 times at night. Maybe radiation's not the best choice for those guys. So these are the sorts of give and take decisions, but at least you're in the ballpark. If you can assign yourself, you say, look, this is what I have, then you start looking at some of these more limited options instead of the long list of possibilities. Now, people are often surprised, even after all these years, when we talk about other things being possibly as good as surgery. And really, what I'm talking about is many other things that are better than surgery. Yes, you heard me right. Better than surgery. I'll say it, better than surgery. And that's still not going to change the way people think, but this is why. There's actually good science in this, hopefully what we're basing our decisions on. There have been comparative studies, for example, and there are a number of these studies out. I'm only going to show one. Surgery outcomes 5 years after treatment versus seed outcomes. So they talk to the patients. This is all done at one center, published in the Journal of Clinical Oncology, very reputable journal. So in the comparison they did, where they did surveys of patients 5 years out, the seed implant patients had better urinary function than the guys that had surgery, better sexual function than the guys that had surgery, and overall were more satisfied with having undergone a seed implant compared to having had surgery. What about cure rates? Well, at least that's what I want to be saved. I don't want to die of prostate cancer. Well, Dr. Peter Grimm gathered together a large number of studies and looked at, because there are no real direct comparative studies, so he gathered all the seed implant studies that were of high quality, all the surgical studies of high quality, and looked at the cure rates of the patients. There had to be at least 100 patients in here for each study. Each dot represents a different study. So this would be 90% cure rate, 80% cure rate, and this is how many years out they check, because the longer you wait, the more time there is for something to come back, right? So this particular study is 12 years out, 80% cure rate. Blue dots are seeds. Okay? Red triangles are surgery. So here's a surgical study, 9 years out, 60% cure rate. 60, 60, 60. Here's a couple, 75, 75, 88. So let's just sort of draw rough circles around. So these are cure rates. Cure rates. Okay? So if you compare the quality of life outcome and the cure rates, the seed implants come out better than surgery on both accounts. All right. No more about that. Now we're going to go on and talk about Azure, or what we call high-risk prostate cancer. That is no previous treatment again. However, high Gleason score or a high PSA over 20, or now you've got scans showing spread outside the gland somewhere, either extracapsular extension, seminal vesicle invasion, lymph node metastasis, and of course, again, you have to scan their body because to make sure there's no spots on the bones. And these types of patients, there is a higher incidence of finding spots someplace else, and then they would move into a different shade if any of these scans were positive. So once again, there are different types of high-risk prostate cancer, what we call the Azure shade of blue. we'll call it high risk, high risk. What if the Gleason score is 9 or 10 versus 8? That makes a difference. That turns out that the grade 5 component is significantly more aggressive than the grade 4 component. What if there's seminal vesicle invasion or pelvic lymph node metastasis? Well, that's demonstrating right up front this is a more serious type of high-risk Azure. What about the other extreme? Are there low-risk forms of Azure? Well, if it's just a grade 8 and it's a very small amount, PSA is low, well, maybe only a couple biopsy cores, or maybe the MRI shows a little tiny spot, or maybe you can't even see anything. We would call that a low-risk Azure. So what are the different ways we would think about treating these people? You have the standard, which is sort of halfway between these things. Standard treatment is similar to the treatment for Teal. So you get IMRT, seed implant. However, the hormone therapy goes for a longer time period, 18 months, not 4 months. And the radiation with IMRT is extended out to cover the lymph nodes in the surrounding area to try and, if there's any microscopic spots, to kill it. And then that's just for standard. If you have the high risk, that's grade 9, or you have proven seminal vesicle invasion, this is investigational, it's not proven yet, but we have better medicines, better hormone treatments, and type of chemotherapy that you might want to consider to try and improve the cure rates. This is not only a high risk, this is a high risk, high risk. And then for the people that have the low risk Azure, really you treat them the same you would maybe a high risk Teal. So maybe 4 months of hormones, IMRT, and seeds would be reasonable. All right, so we're moving through this pretty quickly. We'll have some time for questions at the end. The indigo shade of blue. This is men that have been through treatment with surgery or radiation perhaps, and now the PSA is rising again. That's a fairly reliable indication of a relapse. There's debates about how good PSA is for screening for a newly diagnosed disease, but it's very accurate for detecting a relapse. There are a few exceptions to that, but I'm not going to go into that now. So having previous treatment and then a rising PSA. So the real issue, and it's an honor to follow Dr. Almeida today, who just gave you a talk about scans. And this ability now to have better scans has completely revolutionized the management of indigo. And because we've always been able to detect the relapses with a rising PSA, but the question was, where is the cancer? And with the advent of better radiation treatment in particular, I know you talked a little bit about surgery, but with the advent of better radiation, where they can pinpoint different spots in the body with treatment, this enables us to actually do something about the information once we get it. So the first question then is, where is the cancer if you've got a rising PSA? Is it where the prostate used to be? Is it in the immediately surrounding lymph nodes, or is it some more distant location? You're not going to treat all those people the same, and I'm going to go through and talk to you about that. The other thing we've learned over the years is incredibly important, and it's logical if you think about it, is fast-growing cancers are more serious and dangerous than slow-growing cancers. Duh, right? That's like simple, but it turns out that it plots out really accurately in terms of how, if you look at how fast the PSA is rising, what we call the PSA doubling time. That is a good surrogate for the growth rate of the cancer. And you're going to want to treat faster growing cancers more aggressively and slower growing cancers less aggressively. But we'll come back to that in a second. So the first thing is we want to look at just a visual of the idea of if you find cancer, but it's only where the prostate used to be, and you don't find any other cancer anywhere else with appropriate modern scanning, this type of individual is going to be treated differently than the type of individual that has a local lymph node. Now, if you get into more extensive disease, say in a bone somewhere else, you're no longer indigo anymore. We're going to come to that in a minute. But this situation here is quite a bit different than this situation here. Why? This has the biochemical, the genetic capacity, its proven capacity to spread, as this one is still an open question. So you're talking about two really different situations. This one here may be a pussycat. This one here almost certainly is a potential tiger. So the location tells us more than anything else that we could really look at, and we're going to come back to that rest of that stuff later. All right, so what do you do if the scans are clear? What if it's either we don't see anything at all, and we tend to presume that the cancer is where the prostate used to be, or if we have a scan that lights up where the prostate used to be? And it depends on what you were treated with previously. If a person had radiation and then the PSA starts rising, indicating a relapse, then the natural things to consider are perhaps freezing what's left of the prostate, or they can also do radioactive seed implants in people that haven't had seed implants. Those are the backup plans to try and cure it again. What about rising PSA after surgery? This is often touted as one of the great advantages of surgery. You know, if the surgery fails, then you can radiate where the prostate used to be, and it is very effective. You know, the trouble is when we're talking about Sky, Teal, and Azure, we're not planning for failure, we're planning for success, okay? Gee, I'm so happy I can take radiation. It's a good thing I had surgery, right? So that used to be a real issue when radiation had very poor cure rates. About 10, 15 years ago, radiation has really been transformed technologically in the last 10 to 15 years. In the 1990s, we were a full-time prostate cancer clinic, and we never, ever referred for radiation. Ever. Radiation was horrible. And this is one of the reasons I put radiation up there as one of those scary words. They burned a lot of people, but they cured relatively few. And then when the ones that didn't get cured, they had to try and figure out what to do. We didn't have the seed implant. We didn't know cryotherapy. It was a mess. It was a horrible mess. But once radiation technology changed, then this whole idea of, oh, goody, we can do radiation after surgery, so let's do surgery first, that argument went out the window. But you'll still hear it to this day, amazingly. One of the questions that comes up when you're treating someone with a rising PSA who's failed after radiation or surgery, should we add hormones to try and improve the cure rates? Hormones have side effects, so there's a trade-off. And that question comes down to the PSA doubling time. So one of the things to mention is that it is possible for the PSA doubling time to go so slowly that you don't need to do anything. In other words, 70-year-old guy, his PSA is doubling over 12 months. You can calculate it out that he's going to die of prostate cancer when he's about 132. And so why would we treat the guy? Why would we incur all these side effects? So PSA doubling time between 6 to 12 months, that's a little more iffy. So we talked about doing radiation or cryosurgery or seed implants. You actually can also use hormones without these things. And that's sort of a preference sensitive. You could suppress it with hormones. You could do, you could do surgery, seed implants or cryosurgery. But when you get down to when the PSA is doubling in less than 6 months, that's when you do both. That's when you start getting concerned that you're treating more of a tiger than a pussycat. All right. And I think I might have gotten this scan from Dr. Almeida. It's so beautiful. It's so amazing. This is a cutaway view. You can see the backbone. These are the hip bones, liver, kidneys, and then you see these bright little spots. This is information we never had before. And actually, we did have it in an older, how many of you in the room have heard of something called Combidex? Has anyone heard of Combidex? Just a few. So we had an MRI contrast media that was able to see things like this, and we used to fly people over to Europe until Dr. Almeida blew into town, and does just as well here. And the issues then are, with modern radiation, you can zap those spots, and of course, when you can see something, this is again the indigo stage, but now you're seeing something on a scan. This is a type of cancer that is shown it has a genetic ability to spread, much more dangerous, and it's therefore very logical to consider using combination therapy, maybe even with more powerful hormones, and certainly adding Lupron, and then of course radiation. And there's arguments sometimes that there haven't been any, there isn't any proof that this sort of thing works, that this is all speculative. And I got a consultation from someone from a reputable center saying, you know, it all sounds good on paper. It sounds like a good idea. But, you know, should we be doing this stuff? And our argument is, well, this can be done really rather non-toxically. Why don't we do it until we figure out if it works or not, because we might get some good long-term results. And to do that, I want to do just a quick case report. I don't usually do this, but there were some extenuating circumstances I'll explain in a minute. This is a patient that came that was treated with surgery back in 1995, so he's coming up on his 20th anniversary. 4 years later, relapsed, and he decided to have suppressive treatment with hormones, which he took off and on through a number of years. But in fact, in 2006, we were concerned because his PSA doubling time was picking up, and we actually gave him a short course of chemotherapy to try and knock the PSA down. But this Combidex thing came along, very similar to PET scans, and we were able to, back in 2007, localize the lymph nodes in his pelvis where the cancer was. And so he was treated with radiation, and then came to see me for a couple of years, but got bored because his PSA was always 0, and he stopped seeing me until when he heard that I was coming to give a talk. He actually owns an adobe house here in Albuquerque. And are you here, Jack? We're going to show you off. Can you stand up so that so Jack and his wife Erin took me to breakfast this morning, and I saw his lovely home. And so Jack's most recent PSA is less than 0.1, and his testosterone is recovered. So he had his treatment in 2007, 7 years ago, and he looks like he's cured. So not only can people live longer with appropriate treatment for oligometastatic disease, but they can live better because he hasn't had to take any Lupron or Casodex. Unless you haven't been sneaking any on the side, have you, Jack? No, okay. Because I haven't seen him for 5 years. So anyway, that is, I think, it's worth trying to cure people when they have limited metastatic disease. This is sort of a complex picture that shows cutaway views of how these modern radiation doctors can treat the colored areas where the lymph nodes are and spare all the surrounding structures. It's really amazing technology. They do this with computers. I don't know how they do it. All right, so the last shade of blue, how are we doing on time? We're okay? Okay, great. So what we call the royal shade of blue, this is where people have a rising PSA on Lupron, or they have metastatic disease that's beyond the pelvic lymph nodes. Either one of those puts people into what we call the royal shade of blue, otherwise known as advanced disease. Now, this category breaks down into a lot of subtypes, and it's probably the simplest way to try and distinguish the different subtypes is how they've responded or whether they've had Lupron before. One of the biggest milestones in people with prostate cancer is if they take Lupron and it stops working. That's a defining moment because Lupron historically has been far and away the most potent and powerful anti-cancer maneuver we have. In people with Indigo that go on Lupron with a rising PSA, their average response time is 10 years. There is no other anti-cancer treatment like that available for any other cancer. It's really unique, spectacular. So you can imagine if the Lupron stops working, that's a serious development. So we have people, one category of royal, those that are Lupron resistant. Being Lupron resistant puts you in royal, okay? But there's also people, perhaps, who neglect checking their PSA. And we're going to see this more now that the government's told us we shouldn't check PSA anymore. They come in the office and their PSA is 600. And you get a scan, they've been playing golf, they feel fine, and they got spots all over their body. They have metastatic disease. That's also royal. So kind of two different situations. So we're going to just talk briefly about how we approach treatment for these different situations, and then we'll wrap it up. So let's take this one first. This is less common, thankfully, although it's going to become more common now that we've stopped PSA screening. Basically falls into two categories. People that have a large number of spots that are spread around, and people that just have a few. And I think I might have that picture again, yeah. So you have people that have maybe just one or two, or perhaps 2 or 3 spots with the appropriate scanning versus multiple spots. This is called oligometastatic. Greek means few. It's the only Greek word I think I know, oligo. Oligometastasis, or more extensive disease. This should be treated differently than this, okay? They're both royal, though. All right, so if we have the situation of extensive metastasis, basically you want to adopt an aggressive approach and use multimodality therapy. I think of cancer sort of like, at this stage, like a fire burning out of control. We don't want to, if we've got 3 buckets of water on the stage, I'm not going to just take one and sort of see how it works. I'm going to grab all 3 buckets and throw it on the fire because I know I have to extinguish the fire. I'm not just trying to play with the fire or slow the fire down. So it's a combination approach. The universally agreed upon thing now, due to new studies, is that a person should go on 6 cycles of Taxotere chemotherapy. You know how I conveniently did not use the word chemotherapy here, because I think words matter. It's a medicine. It works. It kills cancer. It's called Taxotere. Unfortunately, it's also chemotherapy. All right, so, and then Lupron. So if they haven't been on Lupron, they start the Lupron, they start the Taxotere, and what we would do is use some of these new improved hormones that they haven't been tested in this setting yet, but we know they're superior because they work when this stops working. They don't have additional side effects, so why wouldn't we use them now? What are we waiting for? I want to use the 3rd bucket of water now. All right, so that's with extensive metastasis. What if there's only just a few metastases? The only difference is that you ask your radiation doctor to sterilize those spots. They can treat the spots on the bone or the lymph nodes easily with virtually 0 side effects. So I would also treat the spots in addition to doing all of this. If there are this is not a good thing, having metastasis. We all agree on that, right? We're going to treat it aggressively. So just in general, and I may have already pointed this out, we want to use aggressive treatment principles, aggressive early combination therapy. We want to get the PSA to 0. That's the goal. You have to monitor blood tests appropriately, and then if you don't succeed or the PSA starts rising, then it's time to add additional treatment or change. Okay? Now, what about the situation? This is more common. What will happen, people pass through, they have surgery, maybe they were in Azure, they have a relapse, they become an Indigo, and then after being on Lupron for a number of years, the Lupron stops working. Well, some of those people have clear scans. PSA starts rising while they're on Lupron, testosterone's low, and the scans don't show anything. So you actually have 4 different scenarios with Lupron resistance. The clear scan one we'll talk about in a second. You can also have the oligo and extensive metastatic situation, which we just went through, but with Lupron resistance. And the treatment's basically the same. Get on chemotherapy. Presumably they haven't been on Zytiga or Xtandi because we don't fit that criteria. So start them. Start those. And if it's oligo, spot radiate. If it's extensive, stick with the medicines. All right, so that's this situation. The scan's clear, and the resistance, I'm going to go through that really quickly with you. It turns out that if a person has Lupron resistance, a rising PSA, the idea that the scans are clear usually means that you're using crummy scans. That's just, there's a lot of older scans, and if you look hard enough, people don't have a rising PSA with a low testosterone without metastatic disease, bottom line. It's there somewhere. It just needs to be found. And you say, well, why is it so important to find it? Do I really want to know about it? And the answer is because there's things we can do about it, and I'll get into that. The types of improved scans, better bone scans. Dr. Almeida talked about this. It turns out that MRI bone surveys, you can go back and find out based on previous surgery, and even the lowly prostate scan. These things can sometimes find where the cancer is. Why is that so important? Well, we talked about spot radiation. There's one other issue, and that has to do with a new type of prostate cancer treatment that harnesses the immune system. Anyone that hasn't heard of a medicine called Provenge, please raise your hand. All right, well-educated audience, excellent. So the main issue with Provenge, because it's almost completely free of side effects, is that it's very expensive. It does prolong life, and I think we would all take it even when we're Indigo stage if we could afford it or if we could get someone else to pay for it. So it turns out that getting it paid for becomes the big issue. And to do that, you must meet these 3 criteria. You have to have a low testosterone while on Lupron, you have to have a rising PSA, and you have to have a documented metastasis. So appropriate scanning to find the metastasis can make the difference of whether you can be eligible for this medicine, which can add a year of life as long as the PSA is under 22, which is, to us, this is very high. The average patient we see that gets Provenge probably has a PSA of 2, not 22. Immune systems work so much better when you get it in early, okay? And that's what Provenge is all about. All right, I think we have 2 more slides. Last category, the 4th category. What do you do if Lupron and Xtandi and Zytiga stop working? How many of you have not heard of Xofigo? Okay? Xofigo is an injectable form of radiation that is smart enough to swim around in the blood and stick to the cancer cells. Isn't that cool? So it has very little toxicity, and it makes people live longer. The FDA approved it about a year ago. It's an injection once a month. Side effects usually are some mild nausea, sometimes some diarrhea. It's effective, and that's all the time we have for Xofigo. Standard chemotherapies, you heard me mention Taxotere or Jevtana. They work better when you combine them with other chemos, which are enumerated here. And then last slide is what about research stuff? It's a big question in people with Royal. There's pros and cons to doing research. They're listed there for you. Sometimes you can get access to new medicines that could not otherwise be obtained. And with the type of new research being done now, there's a lot of exciting stuff. Disadvantages that you usually can't do combination therapy because they want to find out how well it works, and they have to look at it in isolation. That can be a disadvantage. You might end up on a placebo. That's another big disadvantage. So you have to be savvy about this stuff and do your research, but there's definitely potential advantages here.